Good morning, everyone, and thank you for joining Cancer Support Community's 5th Annual Forum on Utilization Management. I'm Courtney Yo-Savage, Senior Vice President of Policy and Advocacy. Before we begin, just a couple of housekeeping items. Today's summit is being recorded and will be available for viewing afterwards. We'll share an email with all participants in the coming days. Please submit any questions you have in the Q&A box throughout the presentations, and we'll do our best to get to them during the Q&A portion of each session. If you have any technical or administrative difficulties, please let us know by using the chat box at the bottom of the screen, and we'll do our best to address them. Now, to kick things off, I would like to introduce Debbie Weir, Chief Executive Officer of Cancer Support Community. Debbie is a social worker by training with 30 years of proven success in nonprofit management. Debbie, thank you for your work to uplift the voices of people impacted by life-changing events and your lead of advocacy efforts to make positive change. I'll pass it over to you.
Hi, everybody. Good morning. Thank you so much for joining us for Cancer Support Community's 5th Annual Summit on Utilization Management. We really appreciate you taking the time to learn about these vital policies and how we can provide support to patients, caregivers, loved ones, and communities impacted by cancer. This summit is really the cornerstone event of Cancer Support Community's Forum on We want to foster thoughtful discussions that engage a broad range of healthcare stakeholders and keeps the focus on patients. We want to ask tough and nuanced questions about when various approaches are acceptable and when they have the potential to harm patients and patient health outcomes. And we want to identify new ideas and promising practices that optimize care based on evidence-based healthcare. We all know that strategies are common policies which, when implemented appropriately in the healthcare system, can enhance the patient experience and improve quality of care and quality of life. However, they can also negatively impact patient access to care and contribute to provider burnout. Since 2019, Cancer Support Community has hosted an annual series of roundtables on critical utilization management policies. This year, we held virtual roundtables to discuss the effect and cost of prior authorization and step therapy on patients and the healthcare system. Over the course of the summit today, we will hear about these issues and other strategies, what has happened since we began these roundtables in 2019, and what to expect and focus on the future. I think it's important to look back to see where we made progress and where are those blocks from making that progress. And it really is all of us together, whether it is manufacturers, patient advocacy organizations, working with legislators to make meaningful change. We're very committed to fostering conversations that inform and engage all stakeholders in the creation and implementation of strategies that include the patient perspective and incentivize cost efficiency through improved patient care and outcomes. We are here today because we believe that we have a role to play in making high quality, accessible, and available care. And I'll also say, through our global Cancer Support Community helpline that we are constantly answering calls from patients and caregivers regarding financial toxicity and their concern about their finances, and also more education that is needed so they may make informed decisions about their care to enhance their experience. I also want to thank very much our sponsors for today. We couldn't do this without your support. We're grateful for your support. Bristol Myers Squibb, GSK, Janssen, Novartis, and Sanofi. And again, thank you for being here. Thank you to all of our presenters today. We're going to learn so much from you. And now I'll give it back to Courtney. Thank you.
Thanks so much, Debbie. So let's just take a moment to preview what we'll be covering today, and then I'm going to turn it over to my esteemed colleagues to introduce themselves. So panel 1 this morning will focus on the impact of the Inflation Reduction Act on patients and their communities, discussing the implementation and unintended consequences of Medicare Part D redesign. The panel will discuss best practices and engagement of patients and caregivers and the disabled community, and the importance of uplifting patient voices and feedback into the policymaking and implementation process. Panel 2 will provide a legislative and regulatory update on utilization management practices currently being discussed by policymakers, and discuss advocacy opportunities in the coming year to improve practices and lessen burdens on patients and caregivers. So it is now my honor to acknowledge the speakers on our first panel, and I'd like to invite them to introduce themselves, starting with Sara van Geertruyden.
Got to turn it off mute. Thank you. Yes, Sara van Geertruyden. I am the Executive Director of the Partnership to Improve Patient Care. Some of you may already be familiar with PIPC, but we are a coalition that was created by Tony Coelho. Tony is a former congressman and wrote the Americans with Disabilities Act and is also a patient with epilepsy. So when PIPC came together, it was really around, and some of you may remember back in 2008, 2009, when comparative effectiveness research was sort of the hot topic on Capitol Hill. PIPC is a coalition that came together, in essence, to promote the creation of the Patient-Centered Outcomes Research Institute in hopes of driving a very patient-centered perspective of how we develop comparative clinical effectiveness research with a real emphasis on clinical benefit for patients and looking at outcomes that matter to patients. And so that's sort of where we got our beginnings, and since have spent a lot of time working towards improving PCORI, making sure PCORI is sort of meeting its mission, but also using those lessons learned to drive better patient engagement practices across the board, and making sure that the patient voice is sort of at the forefront of these value discussions that we are having today.
Thanks, Sara. Barry.
Hi, I'm Barry Liden. I'm the Director of Public Policy for the USC Schaeffer Center for Health Policy and Economics. At USC Schaeffer, we're focused on trying to bring data and research into policymaking. And one of the ways that we've done that in the past is to develop new methods and techniques for really incorporating the patient perspective into value assessment. So we're really passionate about trying to make sure that, we have a lot of economists on staff. So as a lot of economists operate, we want to make sure things are efficient and that we are really truly gathering the right information to make good decisions from a policy perspective at the macro and even down to the individual decision maker level, the patient level, the physician level. And so we have developed a number of different techniques and approaches to try to incorporate what's really the perspective of the patient when we look at things like, let's say, drug pricing. So really excited to be here and to really try to help further the discussion along the path of, how do we really make sure that the system works for the people that it was originally designed to help, and that's the patients, or you and me, who are either currently patients or will be patients at some point in time.
And lastly, Michael Ward. And Michael, I'm going to invite you to introduce yourself and then kick us off with a discussion about Medicare Part D redesign and the Inflation Reduction Act.
All right, thank you, Courtney, and thanks to the cancer support community for hosting all of us today. So Michael Ward, I'm the Vice President of Public Policy and Government Relations at the Alliance for Aging Research. For those of you who haven't had a chance to work with, the Alliance has been around since 1986, started with a focus on procuring funding for the NIH for aging-related research, because there wasn't a ton of funding for diseases such as Alzheimer's at that time. And so we've really been part of the effort to increase funding over the years, but certainly since that time, our remit has expanded, doing a lot of work with the FDA on patient-focused drug development, as well as with CMS, because even if you have the best drug, if you don't have access to it, kind of the point of the research is a little bit muted then. So look forward to this conversation on utilization management. And just to kind of level set, I think, I want to talk a little bit, start the conversation with a little bit of an overview of what's going on in the Medicare program, both kind of on the pro side in terms of expanded access for patients, as well as some challenges, some unintended consequences that we may see in the coming years that bear keeping an eye on, and maybe there may be some opportunities in the near term for some advocacy on to help prevent those potential outcomes from occurring. And so just to start, so in the Inflation Reduction Act, there are a number of provisions that are beneficial for patient access. We see the elimination of copays for vaccines, the $35 insulin policy, and then kind of the two big ticket items that so many of us around this table have pushed for, I think, over the last 5+ years, was really the institution of the creation of an out-of-pocket cap in the Part D program. Right, there was no cap on out-of-pocket spending before. Now there is a $2,000 cap. It bears noting that $2,000 cap starts next year in 2025. However, it will not stay $2,000 forever. It will increase as spending in the Part D program increases. So that $2,000 cap will increase over time. And the second piece is what we called prior to passage the cost smoothing program, which is basically the ability for beneficiaries to pay their out-of-pocket cost, up to those $2,000 or whatever the cap level is in the future, in zero interest payment installments over the course of a plan year. So I think we've been working a lot with our fellow patient groups, and as well as with other stakeholders, including insurers, the pharmacists, and providers over the last year to kind of think through these policies. I think that the $2,000 cap is pretty straightforward in terms of implementation. Everyone's going to, if you have that number of out-of-pocket cost, you will receive that benefit in terms of not having additional cost after that point. However, the smoothing benefit, which is Medicare now calls the Medicare Prescription Payment Plan, is a little different. It's different in that it's an opt-in program. And so beneficiaries have to proactively choose. They have to tell their health plan, is how CMS is currently constructing this, that they want to utilize this benefit. And so there's going to be an immense amount of patient education that is necessary. There are also some challenges in that this isn't saying that this policy doesn't say that, whenever you incur your cost, you have a year to pay it. It's until the end of the plan year. And so if you incur a cost in October and you're opted in, your costs are spread, over October, November, December, rather than over 12 months. So there are some, I think anytime we get math involved, and it becomes very complicated, and it's going to be challenging as we're communicating to patients, especially the patients that are most likely to benefit from this policy. And the third piece has been, the challenge has been where patients are going to be able to opt into this. So, I think about in the case of a beneficiary who may be diagnosed mid-year, maybe mid to late year, with a new condition that requires a relatively expensive Part D therapeutic in order to treat. So they have not opted into smoothing at the beginning of the year, unlike someone who may have a chronic condition that knows that they have these kind of relatively predictable costs, and they want to spread those out over the course of the year. So that this is someone that could potentially benefit from this program. Right now, CMS does not foresee the ability, at least in the initial years of the program, for patients to be able to opt in at the pharmacy counter. And so that means that a beneficiary has to talk to their insurer before they fill their script. And I think, just as someone who utilizes the healthcare system and family members, that's not, you don't go, talk to your doctor and then you're like, oh, on my way to the pharmacy, I need to call my plan and then wait a day and then, have that approved. And then I can go and be able to kind of spread out these costs over the course of a year. And so there are still some real challenges involved with that. And we're certainly, continuing to work with the agency to think through those challenges. Especially if patients have to talk to their plan before they get to the pharmacy counter. What are the upstream ways to do education, including the especially providers that work in specialties that may have more expensive therapeutics? what are the role of providers in helping to provide education in those spaces. So there's a lot of important work to be done and to partner with. The second piece, and I want to talk about just at the top of the conversation today, is maybe a lesser foreseen consequence, at least when considering the huge expanse of legislation that is the IRA. But the IRA also redesigns who is responsible for costs in the catastrophic phase of the benefit. So, currently, once a patient enters the fourth phase of the benefit, which is the catastrophic phase, plans, the payers are responsible for 15% of the cost in that phase. After starting in 2025, they're going to be responsible for 60%. So it's a huge increase in terms of plans and their responsibility for the costs that are incurred by patients in excess of the catastrophic level that is set by CMS. And so as a result, and I think that, whether this was foreseen by some and others, I am not sure, but, I think as we've thought about it, it's really become clear, and certainly in our conversations with payers, is that this is going to result in a drive for increased utilization management techniques, right, in the Medicare program. There isn't a ton of, there isn't honestly a ton of like in Medicare Advantage right now. It's more limited. There's more protections than there are in the commercial space, although it's still not ideal. But plans have said there's also a limit in terms of how much Medicare premiums can increase over the next handful of years as a result of the law. So there's only so many levers that insurers can pull to in their eyes kind of constrain those costs in light of their increased responsibilities. So I know that we're thinking a lot through what are the implications of this for increased use of step therapy, for prior auth, for other forms of because I don't think that, I don't think that that's something that Congress and certainly politically, as we're thinking about this, that is going to be super popular if patients are unable to get kind of access to the drugs they need and have been accustomed to being able to get kind of up to this point. And I think the final point I'll make kind of on utilization management is similar to that. I know that there's certainly a lot of discussion going on around PBMs right now, kind of in the greater context of government discussions and on the Hill. But something that I want to bring up is for drugs that are subject to price negotiation, it remains a question as to if that will impact where PBMs put those drugs on their formularies. Because right now, they can negotiate rebates and so forth with drug companies, which which a lot of the literature in recent years has talked about how that may impact where it goes on a PBM's formulary, if it's on a preferred tier or non-preferred tier or specialty tier. And so with the potential for potentially less less space in terms of the rebate for the PBM to procure on their own behalf and behalf of plans, I think it's an open question as to if that will be an impact. And so I know that I think there's work to be done in terms of making sure there's appropriate safeguards to ensure that doesn't occur.
Thanks so much, Michael. That was really informative. And I think I want to bring this back around to why are we talking about Medicare Part D redesign and cap and smoothing in the context of utilization management? And I think you did a great job of tying that all together. And I think that's what we want this panel to focus on a little bit is hey, this was supposed to be a pretty good thing, right? This was supposed to be an opportunity to lower prescription drug costs and lower that and minimize that immediate out-of-pocket burden to make prescription drugs more accessible in the short term. So why are we talking about all of these negative things? Well, it's Barry, I'll suggest that your economists would probably call those things externalities. They're the unintended consequences, or, not the direct result of pulling the lever, but what happens down the assembly line as these things are implemented. And so that brings us around to the importance of patient engagement, and both being proactive and helping to educate patients, for example, on how to enroll in that smoothing program. But then also, what are some best practices in engaging the patient community, the disability community, so that we can understand the impacts of those policies at the front end and monitor those impacts throughout the implementation process. And so, Sara, I know that you have a lot of experience in, with patient communities and the disability community, and I thought that you might be able to share some insights on what those best practices look like. And I think you're still on mute.
Yes, sorry. And yes, I've been thinking about this a lot, with a lot of the stories that we've been hearing around, particularly with regard to the recent CMS listening sessions and the negotiation process and how those engagement practices went. I mean, we've spent so much time working with entities like PCORI to try to master patient engagement, right? And really advance what we would call the science of patient engagement, as well as just, I always say, there's the science of patient engagement, but then there's also just sitting down with patients and just listening, and, but yeah, I will say there has been a lot that has gone into trying to improve, particularly I feel like on the CMS side, how they handle engagement. I mean, if you look back to when CMS was really pushing for alternative payment models, right? The idea that we wanted everyone in an alternative payment model. And as PIPSI, we came together and said to CMS, well, that's fine, but don't you think that you're going to need some patient advisory panels, groups that are like in the room with you, working to develop those alternative payment models? Shouldn't we be talking about, so in the CMMI statute, there's a provision that says that you're supposed to benchmark the success of these payment models based on patient-centeredness criteria. Well, we've been calling for those patient-centeredness criteria for a decade, and we still haven't seen them. So, I think there's a sense of frustration that, whereas on the one hand, you see PCORI, which is doing actually a very good job of really thinking through what patient engagement looks like and doing it better. I think they're actually about to come out with a new patient engagement rubric. And then on the FDA side, you see patient-focused drug development, where there are some best practices that I think we could be pulling from in order to make sure that voice is, and I would call it goes beyond engagement, right? And I'm not going to take credit for this, but I was having a conversation recently with a disability researcher who pointed out the distinction between engagement and communication, right? I feel like there's a lot of engagement going on where it's come talk to us, let us listen, but there's not a lot of communication, right? Where the information that's being translated or being transferred over to the agency is being heard, and there's opportunities for questions and answers and feedback and a back and forth process, right? I mean, we're very concerned in looking at this from the perspective of like a value assessment process. What kinds of value assessments, what kinds of evidence are they using to make decisions? And that actually goes back to utilization management too, right? Because we've seen an increased use of evidence that the disability community would perceive as being discriminatory and biased, but that information being used to then justify things like step therapy, things like prior authorization. And it's particularly impactful for those communities that have expensive healthcare needs. So the engagement piece is really important, right? It's important that the patient voice be front and center in the evidence, and that the patient voice be allowed to weigh in on what evidence is being used to make decisions, and that those perspectives are just being heard more broadly in terms of, like I appreciate, Courtney, the point that you're getting to in terms of we need to have a process for looking back on what the impact is of all this to make sure that there are no unintended consequences. And if there are unintended consequences, course correcting, right? So anyway, I'm sure Barry has a lot to say on this too.
Well, Barry, I was going to turn it over to you next as well. Sara, that was, in an ideal world, we all use best practices and we communicate effectively with patients. But I've been in health policy for a really long time, and we know how to do this. We slap the policy together, and then we're pretty sure it's going to work. We get to the end and we're like, oh, hey, you know what? We should probably get some patients involved. And so we have a listening session, or we do a survey, or, a focus group, and we get a stamp of approval and we send it on its way. What's wrong with that? Why isn't that going to work, Barry? What? I mean, it's tried and true. That's what everybody does.
Well, it's worked. I guess if you define working as what we have today in the current healthcare system, and the quality of that healthcare is working, then I guess, yeah, we can all go home. But I think the reality is that not only is there always improvement to be had, but I think by a lot of different measures, our current healthcare system is underperforming from the perspective of a lot of different stakeholders. And that can be measured in a number of different ways. But you're right. At USC Schaeffer, we're all about measuring stuff. That's what economists do. And I think one of the things that is missing in this whole discussion around the legislation and the policy that was put in place is truly how to measure the impact of these policy changes on the population that we're talking about. And the issue that I think is really kind of challenging for us in healthcare, I don't know about you, but I've had conversations with friends of mine that don't work in the healthcare space, and they ask me what I do for a living. And I struggle with it because my main focus for the last several years has been around patient engagement. How do you describe to somebody who's not in the healthcare field why you even need patient engagement? Like that's a weird thing. In fact, sometimes I've had to, and I shudder to refer to this. I rarely say it, but sometimes if I don't have enough time, I just say, well, it's kind of like marketing. It's not at all, but it's. The thing missing link here is that we've got many stakeholders involved in the delivery of the product to the ultimate consumer. And those are payers, hospitals or providers and physicians, manufacturers of therapies or technologies. And all of those players have a lot more resources and time and professionals that's all they do. That's their focus all day long. And the ultimate consumer, like my mother-in-law, who lives in Southern California, they don't have time to screw around with this stuff or get to be experts. They trust that we're all figuring out a way to do this for them. And so we've got to figure out a way to bring them in a way that's meaningful and to really have a system that truly reflects what's of importance to them. And so if you're going to measure the success of anything, you need to figure out, well, what are we measuring? What are the things that you want to evaluate and set targets for those metrics? And the first place we should be going is to the patient and the patient community to identify before anybody has a conversation about any of this, what's important to them. And there are techniques to do that have been developed over many years. A lot of companies in the private sector have developed techniques to evaluate and do market research and analysis to figure out what the customer wants and what they need and what they'd be willing to pay for different attributes. There are techniques that can be used to do the same thing with patient communities that are relatively, I would call them non-invasive. You can take a sample of a community, get a lot of responses through a fairly simple survey, and get quantitative evidence that can help give us input into what's important to the patient community. In the case of the IRA and some of the provisions that have been implemented here, some that have been discussed here, but particularly with regards to the price fixing, price negotiations that CMS has implemented or is implementing, there's some trade-offs there that I think it'd be important for CMS to understand. If their objective is to protect the beneficiary, they should be asking beneficiaries what's important to them and help prioritize from their perspective what's important. They did have these listening sessions. Kudos to them to at least take a step in the right direction. But as Sara mentioned, there are a lot of different techniques that other organizations within the government have used to really reach out to and engage people and learn more about what's important to them. FDA, I think, is a great example. In fact, actually, I'll go to the Device Center, CDRH, has really paved the way and led the approach to incorporating patient perspectives into their decision-making, developing metrics, identifying what is important to patients, even identifying what the direction and movement of an endpoint should be to evaluate whether or not technology could or should be approved. It is science, but it's not hard science. It's pretty straightforward research that can be brought to bear. So CMS has an opportunity to collect a lot of different forms of data from the patient community: qualitative, quantitative, direct research, and sometimes indirect research that can be accessed. For example, patient experience data can be collected through a number of different methods that are non-invasive, that don't really require direct intervention by the patient, that we can use to monitor patient health and patient outcomes that are important to the patient community. So I think this is truly a huge opportunity for CMS to build a system to be able to identify priorities, what's important to patients, figure out how to measure the performance on those priorities. And in the case of drug price negotiations, what's really important to patients in terms of trade-offs could be, access to a product or to a drug at a certain price for now, or access to future drugs at maybe different prices in the future. And there are ways to assess how important that is to patients, and there are ways to figure out whether or not we're achieving our goals. So I'm actually in some ways excited, because there's an opportunity for us to further bring the patient perspective into CMS's process. And I think they've gotten enough feedback that we are at a spot where they are at least open to listening to different ways to do that. And that's why I'm excited that, we here in this community have an opportunity to really come to the table and help CMS do a better job.
That was a more optimistic spin than I anticipated from you. And I appreciate that. I am going to turn it over to Michael, though, because I know, so both Barry and Sara mentioned the CMS listening sessions. I know that many of us participated in at least one of those. What were your thoughts? Can you talk a little bit about those listening sessions, what their purpose was, and how you felt that they went?
Yeah, I think, certainly, so there was a listening session, or 10 listening sessions, one for each drug that was subject to negotiation. For, based on how CMS selected the first 10 drugs, which I don't think we have, clear line of sight into necessarily. There were certainly some therapeutic areas that had multiple drugs that were included on the list. Some that had fewer. There were certainly surprises, I think, kind of and we were thinking in terms of, if you just looked at the top 10 spending versus kind of what was selected, there wasn't clear alignment there necessarily on some of the drugs. And so, so in terms of the listening sessions, they were scheduled to be an hour and a half long. There were up to 20 presenters, and each presenter was to receive 3 minutes. And I'll just talk from my perspective, and as someone who, is engaged in these things regularly, I found it, I noticed multiple kind of pain points along the way that, if I were a patient, especially as someone who is living with one of these, one of these conditions that was being treated by one of these therapeutics, I would, at any point, you think about these friction points, they could be points where a patient could turn away and say, this isn't for me. I don't see myself in this process. So I know, for example, even just to kind of look at, the questions for written feedback, because there's a written feedback opportunity prior to the listening sessions, you had to enter your email address into the system and submit it before you could look at the questions for the written feedback, which for some folks, they may say, okay, what am I signing myself up for? I don't really know what I'm getting myself into yet. Do I really want to, am I signing up to do this without knowing what I'm getting myself into? I know during the listening session process, I heard from colleagues that were also presenting that talked about they had experience with, loved ones that had since passed that they wanted to share during these listening sessions, but CMS told them that they needed to receive power of attorney to share because there was HIPAA concerns. There was a lot of hiccups here, and I'll say that, and I think as a cumulative result of all of these things that as I was kind of alluding to, patients didn't necessarily see themselves in this process. It was unclear what the type of information to various point that CMS was looking to receive from patients in this, quite frankly, very limited time. I know that, I had 3 minutes and I was trying to talk through, five or six points I wanted to make. And there was, you could kind of allude to data. You couldn't really actually talk to data points that were important. And as a result of patients not seeing themselves in this process, or maybe being, it was a live format. I know there were clinicians that were participating as well. Some of them, had a procedure run long, and so they couldn't join the prep call 30 minutes ahead of time, and so they tried to join, maybe 1 or 2 minutes into the call because they had a later speaking slot, and CMS said, no, you kind of missed your opportunity here. So I think as a result of kind of all of these friction points, I don't think CMS received kind of the level of engagement that they thought. I know during the session I spoke in, which was the final session, like I said, there was 20 slots and there ended up being 11 speakers. And so we had a listening session that was 35 minutes long. That doesn't seem like much of a listening session when you're thinking about something that impacts millions of beneficiaries. And so I think that it's really important as moving forward, thinking about these things, to take all these lessons and communicate them to CMS, but also really get across the point that that CMS needs to take away that if they had less participation than they wanted, then it may be due to these factors rather than lack of interest. They should not stop what they're doing in terms of making strides on patient engagement because they didn't have 20 speakers in each session.
That's a really good point, and one that I think that our collective communities should be continuing to make. That you can't look at the evidence and assume that why it happened the way it happened, why there wasn't as much engagement, for example. In your discussion about these listening sessions and Barry, your comment about the negotiations, it does raise an interesting question. It's a little bit on the rhetorical side, but I'm going to pose it anyway and see if I can tempt one of you to jump in. On whose behalf is CMS negotiating? CMS is a payer. CMS is an organization that determines what appropriate care is. And now CMS is charged with soliciting patient and caregiver feedback and provider feedback. Michael, you mentioned that providers were participating on that call, and that is not something that we've heard very much about at all in the context of Medicare drug price negotiations. On whose behalf is CMS negotiating? Are they negotiating on behalf of the patients who are accessing the drugs? Are they negotiating as a payer who just wants the lowest possible price? Are they negotiating as somebody who adjudicates what appropriate therapy is, regardless, with or without the context of how that therapy will impact individual patients and their family members. Who's showing up at that table? Like I said, it was a little bit rhetorical.
Good question. No, I mean,
Hey,
just in our conversation, I mean, I do think that CMS sees itself as a payer, right? So that does, that being said, on the other hand, it is interesting how much CMS has emphasized efforts towards health equity, efforts towards engagement, addressing people with disabilities and collecting data. And so, I feel like there is an opportunity for CMS to be a different kind of payer, right? And that is, I think, what people wanted out of this process. But the fact that they're not looking harder at FDA and entities like FDA and PCORI as models, right, I think is concerning. I mean, that being said, I do think there are a lot of opportunities here for us to share with them where we think those best practices are, and to hope that they will make those changes as they go forward. And I also think that, if you look at the agency more broadly, there are efforts to ensure that the evidence on which they make decisions is not biased or discriminatory. We're seeing this as part of a lot of the proposed rulemaking that's coming out of the agency related to healthcare non-discrimination, particularly with people with disabilities, that they understand that there are certain types of evidence that can lead to discriminatory decision-making. And so I think this is going to be an interesting process of trying to help CMS understand that there's a patient voice that should be taking precedent in terms of how they make decisions. So I don't.
Yeah, I think I'm going to make a kind of a comment that's, I hate to be negative, but I think part of the reason that we see CMS behaving the way they do is because they, like a lot of payers, see it as they are representing the patient and the providers in the community against the drug makers. They see it as an adversarial relationship. These big companies are charging an arm and a leg, and they shouldn't get away with it forever. We're here to protect the future patients out there who need to have a trust fund that exists, and so that we can afford to pay for other stuff, not just these drugs. The current patients who can't afford to pay because this is too much money, all that stuff. That's their mindset. And that's a really unfortunate kind of adversarial way to look at, I think, to look at how we all come to the table with solutions. People who, manufacturers who are in the business to try to create solutions to problems should be seen as a partner in developing and delivering improved public health. And I think that that's part of the challenge that we have, is that there's this perception that this negotiation is across the table, just like in a lawsuit, and you've got one side against the other, it's adversarial, and that other side is industry. And that's really the wrong way of looking at it. And I do think that there is an opportunity for industry to partner with CMS and to demonstrate goodwill by coming to the table with information that could help CMS see things through their beneficiaries' eyes. And I think industry has done that in the past to provide data and information that they've been able to collect in partnership with patient groups to help inform CMS about what the patient community really wants. Because let's be realistic, CMS does not have the resources that we would love them to have to be able to really do this kind of outreach to patient groups like FDA has built over the last several years. It's going to take some time for them to do that. So to the degree that they can lean on and really partner and trust industry to come to the table with data that helps demonstrate how the value of the drug is perceived through the eyes of the patient, that can be really helpful. But I unfortunately, I think this is almost a societal challenge that we have in terms of how a lot of people see industry. And I think that there's something we got to figure out how to address.
And can I just chime in quickly? I think, because I appreciate your point about partnership, but I would also argue that like FDA partners with patient groups, that CMS should be doing the same thing. I mean, there is an opportunity there for CMS to partner with the groups that actually represent the patients that they are, for whom they're they're supposed to be negotiating on behalf, right? If we're in an ideal world. But CMS should be partnering with those patient groups, in my opinion. And because those patient groups can provide opportunities. I mean, a lot of them, some have registries, some don't, but there are opportunities for those groups to reach out into their communities and get the kind of information that CMS wants in terms of a better understanding clinical benefit. Right. But they have to look at patients as partners in order to do that.
So go ahead, Michael.
Oh,
Michael will agree with me.
I was just nodding in agreement, as Sarah mentioned.
Well, so we only have a minute or so left. I do want to encourage, and I know that we have some of those companies who have been impacted by this first round of drug negotiations in the audience, and they're more than welcome to chime in with questions, as are the rest of you. And I encourage you to submit any questions in the Q&A. But as we're drawing to a close, I mean, it does seem from what you both just said just now, Sara and Barry, that the opportunity is really with the patient advocacy organizations to bring folks together to have these conversations in a productive way. Do you see there being an appetite there? I mean, we have our hands full already. I mean, Michael, one of the questions that I was going to ask you, and we didn't even get to it, was, what can we as patient advocacy organizations do to help educate the patient community about the smoothing program and how to opt in? I mean, that's going to be a huge lift. So it does seem like a lot of this is falling to the patient community to sort of figure it out, and slap some paste on it and hope that it sticks together. What can we do to bring all of these stakeholders together? If we're that uniting bind, if we're that sort of glue, how do we decide what to do, and how do we bring folks together?
Yeah, I mean, I think it just takes, someone just needs to raise their hand, right? I know, for example, in the smoothing space, I know that we've been very active, and like I said, we bring together AARP, bring together all sorts of groups to really think about these issues and what are the issues in different stakeholder groups, and what are the commonalities that we can talk about, and common language that CMS will help define, but we're still waiting for direction. But we're also trying to make a push right now to get those providers involved in education, because it's, there's so many other issues that providers think about day to day that adding another thing to workflow is probably not high on the list of things they want to think, they want to prioritize when thinking about all the other challenges that go on. And so, raising the awareness of this, it is up to the patient community to do that. And I think on these other issues that we're talking about, I think it's raising awareness of it. So, right. So if we're talking about unintended consequences of Part D redesign, talk to CMS. I know we've already been talking to CMS, but also raise this to Congress, right? Is there opportunity for, I know that, we're trying to think through efforts maybe to have Congress weigh in with the agency to say, this is, we want you to create actual safeguards around utilization management, not just rely on good intentions from plans to hope that this doesn't happen. So, I think that there is a lot of work to be done ahead, and we just all need to raise our hand and be willing to link arms with one another, because together we're stronger than we are separately.
Absolutely. Sara and Barry, any closing thoughts?
No, I think, I love how we ended it. I think that makes a lot of sense.
Barry? All right, so we have our work cut out for us. I guess that's the main takeaway. But I think that with the esteemed panel that we just saw, I think that there's plenty of leadership in this area. And and we don't speak for patients. We advocate on their behalf. And it's our job to put them in the rooms and make sure that their voices are heard. And so I think that maybe is my main takeaway from this session is we have to make sure that we are knocking down those doors and making sure that we are getting patients, caregivers, folks with disabilities in the room so that their voices can be a part of these conversations. So I appreciate your time. We're going to take a quick break. Encourage everybody to join us for our second panel coming up in just a little bit, but I hope you all join me in thanking our panelists, Sara van Geertruyden, Barry Liden, and Michael Ward for their time and expertise this morning, and look forward to hearing more from them and all that we have to do.
Thank you.
Thank you all. Please join us on the other side of the break. All right, welcome back, everyone. Welcome back to Cancer Support Community's Utilization Management Summit. I'm excited to showcase our second panel to provide updates and insights into the current legislative and regulatory landscape of utilization management and how we can improve practices in 2024. Just like last time, I'm going to invite my esteemed colleagues to introduce themselves. I'm going to go in order on my screen. So Greg, please introduce yourself to our participants.
Thanks so much, Courtney. Thanks for the introduction, and many thanks for the cancer support community for hosting this discussion on this really important topic of utilization management and impact on patients. Really pleased and honored to be here as part of this distinguished panel of experts and colleagues to talk about some of these important issues. Just a little bit of background for our audience. I have a 20+ year career in public policy and an advocacy space, including leading public policy and advocacy efforts for several large healthcare organizations and associations, including most recently for the past 2 years as Vice President of Policy and Research for the Better Medicare Alliance. Prior to that, I was Senior Vice President for Policy at AHIP and also held senior policymaking roles at Pharma and Blue Cross Blue Shield Association. Started my career in Washington, working on Capitol Hill on the legislative staff for Senator Chris Dodd of Connecticut. Also honored to serve on the Cancer Support Community's Cancer Policy Institute Advisory Board, which brings together patient advocates and policy experts to really elevate and make sure the voices of cancer patients are central to the policymaking process. And, you know, just so pleased to be part of that important advisory group, especially on topics such as this. You know, and medical management, you know, obviously a feature of both public and private health insurance programs. Courtney, to your point, I think when these tools are used appropriately, they can be an important part of, you know, making sure that patients have access to safe, effective, and high quality care. But the key issue is when implemented appropriately, these tools can do that. There continues to be a lot of scrutiny about how these tools are being applied, both at the federal and state level. And, you know, policymakers have been responsive to those stakeholder concerns raised by patient advocates and experts. I know we'll talk a little bit about later on in the panel about, you know, CMS's efforts to streamline and reform the prior authorization process in the programs that they administer, efforts at the state and federal level. And then there's also bipartisan interest in Congress in really looking at ways to, you know, streamline the process, ensure accountability and transparency, and really make sure that, you know, the decisions that go into the tools, these and prior authorization tools, are really aligned with the best medical evidence and best practices. Really, that's how these tools work. If they're tools for kind of blunt cost control, we have real issues with patient access. So again, really thrilled to be part of this panel of experts, and I'll turn it over to my colleagues and looking forward to the discussion.
Well, thanks so much, Greg. And speaking of patient advocates and experts, pleased to be joined by Peggy Tai, who has been working on utilization management, specifically prior authorization for quite some time. So Peggy.
Thanks, Courtney. So I'm Peggy Tai. I'm a principal at Powers Law. So I am a lawyer and a lobbyist, and I like to say that my family still talks to me. So at Thanksgiving, I wish they didn't talk to me as much. But anyway, because they have opinions about Congress. Can you imagine? So I started my career a long time ago with the Health Insurance Association of America, which was the predecessor to AHIP. So I know a little bit about insurance. And then a couple of years after that, I worked at the American Medical Association. So I knew the doctor's perspective on insurance, and the twain don't often meet. So I'm an odd bird in the sense that I've worked in those two different spaces, the provider and the insurance space. I also have a close connection in that we run a coalition for cancer early detection called the Cancer Early Detection Alliance. So we have a sweet spot, if you will, in the cancer space. I also formed the Regulatory Relief Coalition, and the Regulatory Relief Coalition is the author I mean, Congress is always the author of bills. It's never the advocates. But we're the author of the Seniors Access to Timely Care Act. And that bill has had terrific success, except for the passage of it. But other than that, we've had terrific success, and we are hopeful for the passage of it going forward. Some of you on the phone are endorsing organizations of that legislation. There's over 500. And as I look back at that list of endorsing organizations, I think to myself, look at the pharma community, look at the cancer community. It's a huge percentage of those 500 endorsers, and we appreciate that you are supportive of that legislation. In short, the legislation is trying to make more transparent Medicare Advantage's use of prior authorization. And I'm happy to say that BMA, Greg's group, endorsed the legislation, and we greatly appreciate that. We'll get into this later. I know we're waiting for a rule to come out before we further advance the legislation, and we'll talk about that in a minute.
Anna, speaking of advocates and endorsers of that legislation.
Thanks for having me. I'm Anna Hyde, Vice President of Advocacy and Access for the Arthritis Foundation. I have a lot of thoughts about all of these issues. I definitely agree with what Greg said in terms of when used appropriately, can be a helpful tool. I think that's a really important nuance that often gets missed. Sometimes folks want to paint a broad brush that these things, step therapy or prior auth, should be banned. And I don't think that's what any of us are advocating. It's just the inappropriate use of it. There have been some really interesting data points and pieces this year that I think have really put a fine point on prior auth in particular. I think all of us have probably seen some of the ProPublica pieces and investigative pieces about some of the horror stories people have to go through in order to get access to their medications. And the OIG reports that came out over the past couple of years, there have been several that have come out showing the high rates of prior auth in Medicare Advantage plans. So there are a lot of solutions out there. And I know we'll get into that a little bit more, but just to maybe backtrack a little bit, I've been with Arthritis Foundation for 9 years now. And before that, I was with the American Congress of OBGYN. So I've done the provider and the patient world, which is really fun. And I love to maintain really close connections with our provider friends, because it just goes hand in hand. I mean, what we're really all about is maximizing the experience of care, which of course involves the provider and the patient. And we're always about protecting that relationship. So that's really kind of the essence of what all of our advocacy is about. And I'll turn it over to Rachel. I'll just pass the buck right over, Courtney.
Perfect. Thank you, Rachel.
All right. Thank you, Anna and Courtney, and all of you. I'm really glad to be here to have this conversation today. I'm Rachel Klein. I'm the Deputy Executive Director of the AIDS Institute. I have been with the AIDS Institute about 5 years now, and I have spent about 25 years advocating in federal health policy issues, the whole time just for patient organizations. So I have always been on the patient side. Spent the bulk of my career in an organization called Families USA, where I advocated for expanding access to health insurance coverage for low-income people, mostly through Medicaid and the Children's Health Insurance Program. And also we were very instrumental in working on the Affordable Care Act. So I'm really happy that we've jumped into this conversation talking about some of these really important issues that are really affecting patients' access to care. And I know we're focusing a lot on prior authorization here, but I would sort of always feel a little bit remiss if we don't, discuss how prior authorization, which is sort of this one piece of the puzzle, fits in to the larger healthcare system and the experience that patients have, which, is very, very confusing. We have a really difficult system to navigate for people, and mostly a system that people end up navigating when they are very sick or caring for somebody who is very sick, which is not the ideal time for most people to try to be thinking about creative ways to surmount administrative hurdles. So I'm really excited for us to jump in and have this discussion.
Well, thanks, Rachel. And I think that's a great segue to the first question that I was going to send over to you. So in the recent Medicare Advantage proposed rule, CMS actually sort of in the context of the broader utilization management perspective, CMS wrote, CMS understands that utilization management is an important means to coordinate care, reduce inappropriate utilization, and promote cost-efficient care. From the patient perspective, does that statement resonate? Can there be a benefit to utilization management practices like prior auth or other utilization management practices? I mean, I think that we sort of established that in the introduction, but what does that look like? What is the benefit? What is the purpose? What is the real purpose for these types of policies? And how do they impact patients and providers?
So I think there's sort of what is the real purpose can be taken a bunch of different ways, right? Like there is the sort of theoretical purpose that these policies serve, and in their sort of inception and on paper, right? And in the sort of purest form, you might think of utilization management as sort of enhanced communication practices, right? Between all of the different players in the system. It's sort of a backdoor way for providers to talk to the payers and make sure that the patient is getting the appropriate care, right? It can serve as sort of a system of checks and balances if it was implemented in a perfect system, you know, where everybody is really knowledgeable about how everything works. And the whole point of that system was to make sure that people were getting the care that they needed quickly, easily, and affordably. And unfortunately, we are not living in that perfect system, right? We are living in a very, very different system where I think too much of the time, the point is to put barriers in place so that people have to jump through hurdles in order to get access to the care that they need. And whether it is through sort of a direct intent or as the result of many different complications sort of intersecting with one another, the reality for patients, who, as I mentioned earlier, are usually not in the best of circumstances when they're navigating the system, is that there are, you know, there's a lot of confusion about what's happening behind the scenes. Who should I call? What is going to happen next? Am I going to get the care that I need? And that usually results in usually too often, that results in delayed care or lack of care because the patient has sort of lost the thread in the middle of all of this, or because the care has been denied appropriately or inappropriately. And so I think what we are seeing is that, you know, at the end of the day, what's happening right now is that all of these different forces at work are creating a system that becomes really unmanageable for patients, which leads to not only delayed and denied care, but also greater medical debt, where people may be forced to pay for care out of their own pocket or try to because the system isn't picking up the slack. So I think, you know, that is a real problem. And I do want to go back to my point that this is part of a bigger system, because remember that as a patient with a serious and chronic illness, the first thing you have to do is figure out how to find a provider who can care for you, is in your insurance network, and to whom you is taking new patients and to whom you can get easily, right? And so they're sort of navigating, getting the right providers, going through not just prior authorization, but a whole suite of utilization management techniques that can include restrictive formularies, that can include, you know, step therapy, before we even sort of get to the point where you found the right treatment for you at the right time to help your condition. And then I think, you know, the other problem that we face is that even if you've navigated all of that successfully, that doesn't guarantee on the back end that that care is going to be paid for, or that you can afford to get that care. I think what we are starting to hear more frequently is people who've gone through prior authorization, gotten an approval, and then the insurer denies the claim on the back end because that doesn't guarantee payment. And I think that's incredibly confusing for people, right? And really, really discouraging too, when you're having to navigate this over and over and over again. And then, of course, you know, there's still high cost sharing, and then people have to deal with things like copay accumulator adjustment policies and alternative funding programs and all sorts of things in the back end that can affect whether or not a patient can actually afford to get the care that's been approved for them. And they may have to go through prior authorization over and over and over again, right? Even if nothing has changed in their life, once they found that right treatment that that prior authorization needs to be renewed periodically. And if you're dealing with multiple conditions or multiple treatments, you may have to be going through prior authorization, quite a lot. And so it's just a sort of mound of complications that the patients are really grappling with.
Well, so Rachel, you've painted a fairly gloomy picture. But we live in a society where we're supposed to be able to fix these kinds of things. And I'm looking at the folks who are on this screen, and these are esteemed colleagues who I've known for a very long time, who are very adept at coming up, there ought to be a law. Well, these are the guys who do it, right? So, Peggy, you talked about the efforts to reform prior auth and your insights that have helped to formulate legislation to reform prior authorization, and taking that before Congress. But you also mentioned that there's some regulatory stuff afoot, and that same Medicare Advantage proposed rule that I referenced in my earlier question also says that in the April 2023 final rule, CMS adopted several important guardrails to ensure utilization management policies and procedures are used and associated coverage decisions are made in ways that ensure timely and appropriate access to covered items and services for people enrolled in MA plans. Is that enough? Did they fix it? Are we done?
Yeah, we'll see when the rule comes out. So the journey began really with the complaints that, frankly, I had heard for 20 years. The minute I walked in the door of the AMA, it was, do you know what prior authorization is? And I was young. I'm like, I don't know what that is. I don't go see the doctor all the time. What do I know? And then I learned what it meant to doctors and what it meant to patients and how difficult it was. So in having a conversation with some of my friends from the Medical Specialty Society, I said, can't we do something about this? Why aren't we writing a bill? And we started talking about what a bill would look like. And the AMA and the insurers got together and wrote what they called the consensus statement. The consensus statement was basically how Greg just described this, and Courtney and Rachel have just said it. When it is used appropriately, it is okay. When it is not used appropriately, it's a big problem. So how do we do this better? And those groups, the insurers and the doctors, got together on not one piece of paper, I think it was 7 pieces of paper, and said, this is how. So there's agreement. Okay, so we took that agreement and said, why don't we write it into a bill? So that was our starting point of saying, here's what we already agree on, which is why we have some insurers supporting this legislation. The path is modest transparency. Tell us what the rules are. If you told us what the rules are, then we would know how to behave, and you could have proper oversight of the program. As Anna was saying earlier, I think, is there no mandates in the seniors bill that say you can't use prior authorization? That wouldn't make any sense. From a policy perspective, that doesn't make any sense. We can't just abolish it. As much as I know many of the physicians I work for want to abolish it, we're not doing that. So it's a middle ground approach. And then it moved into the administration took that very successful or well-supported bill with hundreds of members of Congress who had signed on to it and hundreds of endorsing organizations, and wrote a regulation that mirrored a lot of the bill. So I think, favorite compliment of all time is a staffer said to me about a month ago, you made the administration pay attention. That's what your bill did. Your bill made the administration realize they had something here, and it was a good idea. So when they ran with it in the proposed rule, they borrowed a lot from the bill, and they added some other bells and whistles. And those bells and whistles are really important because I think, in a sense, the rule is slightly stronger than the bill. So then what happens? So the rule comes out, the price of our bill should go down. And everybody knows in this Congress, they don't have any money at all. And we believe that knocking that price down could actually advance the legislation. Why do you need a rule and the legislation? Because you need something codified. If something can change in another administration, you don't want that. You want to have a bill pass into law. So to the extent to which the rule does things that in Congress doesn't have to do anymore because the rule did it, then we have a smaller bill, and that's okay. But it's the 1-2 punch of the rule and the bill that would effectively bring that more of transparency in, so we'd know what the rules are, so that prior authorization would be limited in a better way so that patients could have the access that they are legally required to get from Medicare Advantage. And the rule is bigger than just Medicare Advantage. It covers Medicaid and other payers. So it isn't just about Medicare Advantage. I think that's important. The rule and the bill don't match equally. And there's a couple rules, by the way. It's not just one rule. But that particular rule I'm talking on electronic prescribing doesn't identically match because it's bigger. It's more important. So we started something that will be bigger and will be better for patients and their access and the transparency of how this system works, so that physicians and patients can have that access to care that Medicare promises them. There you go.
Sorry about that. Greg, I didn't want to interrupt anybody and or my coworker, my four-legged coworker. Greg, I want to turn to you because with your expertise on Medicare Advantage as well, and although Peggy just pointed out the legislation doesn't just focus on MA, but
The rule, you mean? The rule, you mean?
Yeah, sorry.
The legislation just does, the rule doesn't.
Yes, gotcha. Thank you. What are your thoughts on sort of the progress that we have made in the regulatory setting thus far in the MA space?
Thanks, Courtney. Yeah, I think agree with Peggy that these are really important regulations and important steps that CMS has taken to kind of streamline on and improve the prior authorization process, particularly in Medicare Advantage. And so these changes will go into effect next year. They're really focused on protecting beneficiaries, ensuring continuity of care. To Peggy's point about just sort of the black box sort of nature of UM and the clinical criteria, there's going to be new reporting and transparency requirements, including requiring plans to establish a UM committee for the first time, really similar to how it works in Part D as far as, formulary design. These are going to be practices that have to be annually reviewed, has to be chaired by a medical director and a majority of physicians to really make sure that these policies are in alignment with best medical practices and clinical practice guidelines. So, critically important rules, I think, that really address a lot of the stakeholder and patient concerns about the burdens that prior authorization can place both on patients, but also providers too, as far as, paperwork. And that's really where the electronic prescribing rule comes in, which, as Peggy mentioned, is broader than Medicare Advantage. I do think there's still more to be done too. Again, in an ideal world, UM is really a tool, a clinical tool to reduce, waste, inefficiency, and even potentially harmful care. So you think about, how plans, design formularies when there's two therapies and they're equally effective, but one is lower cost. People understand, how these tools can be used that way, or, screening for back pain. And so there is a lot of waste and inefficiency in the healthcare system. I think the issue is we don't live in an ideal world. And I think some of these, tools have been used really as more blunt cost control, as opposed to really making sure the patient has access to evidence-based, clinically appropriate care that's right for them. But as far as what more needs to be done, I do think there's a lot of alignment between what CMS has finalized that will go into effect for Medicare Advantage next year and the Del Bene Seniors Timely Access to Care Act. But I think there's still some gaps to fill. So the legislation, the bipartisan legislation that we were discussing earlier, really contemplates sort of real-time decision-making for prior authorization, particularly as it relates to commonly used services. So the way people think about this is, and states have done some regulation in this area, sort of like a gold card for providers. So providers are, working are successful in sort of delivering high quality, effective care that's kind of consistent with best standard practices. why are we then putting prior authorization requirements on providers that are already sort of, adhering to these best, clinical best practices? So it's been called gold card or real-time decision making. So that's a feature of the legislation that's really not reflected in the regulatory process. Another is really tight, condensing the time frame around urgent care, making that shorter, that these decisions need to be turned around in 24 hours. To Rachel's point earlier, if this care is delayed, it could be care denied, and this is really a real, patient barrier that's been identified. So I think there's a couple of areas where I think the legislation addresses issues that have not been addressed on the regulatory side, and really do see, how they're complementary. So they're in alignment, but I think there's also, more to be done there. And then one final point is, now there's new regulations have been proposed in the Medicare Advantage space, including requiring prior authorization processes to, consider health equity implications, which I think is something that, will get a lot of stakeholder and patient interest in. These tools, however important, you really need to look at their impact on the individual patient level, and are they working to close gaps in care or actually create them? So, kudos to CMS has taken a lot of important steps, also in Congress as well. But I think Courtney, and to the panelists, I think there's also more that needs to be done in this space as well.
So Anna, how do we get it done? You've been in the trenches trying to advance this legislation and other legislation. How do we make the case? How do we get Congress to take action? Do you have any, what are some best practices from the patient advocacy side? How do we bring data? How do we bring stories to Capitol Hill?
Well, I hate to be gloomy, but I think to what Peggy mentioned earlier, ideally, the proposed rule, when finalized, will bring down the overall score. I think that's been the real Achilles heel here. It's kind of ridiculous that this legislation that has over 500 endorsing organizations in the last Congress had over 300 co-sponsors in the House, passed the House, still has not passed Congress. That's widely supported. And we've brought the data and the stories and those things. And I think that has all helped, certainly, to get to that level of support that we have, but yet it still has not passed. I think the money is certainly a big part of it, but not the whole story. There are things that are both discouraging and encouraging. One thing that's discouraging is that neither the legislation nor the rules that we're talking about here cover prescription drugs. So we're talking about items and services, but we're not talking about prescription drugs, which is a huge administrative barrier to my patient population, and certainly many others as well. So when I'm thinking about it, what is really needed for the patient community to have more streamlined access to care, there are some big gaping holes that it's hard to imagine could be surmounted any time in the near future. I really want to know what Peggy's reaction is to what I'm saying.
Yeah, no,
Because,
I agree with everything everybody said. How weird is that? I agree with everything everybody said. That never happens. But you make a really good point. I remember that part of the impetus for our bill was that Representative Kelly said, I want to pass a bill like Schweikert passed a bill, and that was on drugs. So, but I believe it was only in Medicare Advantage. Was that right? So it's that you don't have the rest of the other insurance carriers, if you will, covered by. So there's a good idea sitting there waiting to be jumped on. And items and services is rather broad, but I think you're right. There's some more fine tuning that needs to be done. And this has to get done. Ridiculous is the kindest word I can think of when you have that kind of support in Congress. CBO in my mind is a 4-letter word. I'm just frankly angry that I read this much from CBO and then I read in the CMS rule their analysis that says this will save money. So the CMS, the experts at CMS who know healthcare, sorry CBO, but they're going to know healthcare better than you, are saying it's going to be a saver, and we're stalled. We're paralyzed in Congress because of CBO. That's maddening to me.
Right.
I just want to, I'm sorry, just to level set for everybody. I just want to, we're talking about scores and cost and CBO. I just want to level set. So anytime Congress passes legislation that has a cost associated with it, they have to come up with a way to pay for it, right? So it's part of the rules of Congress. It's how they've operated for the past number of years to make sure that we're not just spending or creating all of these unfunded mandates. And so in order to assess how much a policy is going to cost to implement, there's an organization called the Congressional Budget Office, and they are the bean counters who go through and say, okay, this bill is going to cost X number of dollars to implement. And the conceit that we're talking about here is that CBO is so convinced that prior authorization is a utilization management tool that is intended to restrict access to care such that it keeps patients from incurring additional healthcare costs, right? So despite the fact that we're talking about utilization management as a tool that can help to improve care quality, care coordination, and make sure that we are getting efficient, high quality care, CBO looks at it and says, no, this is a cost control policy. This is a way to make sure that people are not spending money willy-nilly. And so they interpret any effort to restrict private insurance companies from employing those tactics as something that will cost money. So despite the fact that the policy, we've all sort of tacitly agreed, has reasonably positive intentions, CBO has called a spade and has decided, no, this is really just a cost control measure. And if you tie their hands, it's going to cost money. And what Peggy has said is the administrative agency that is responsible for this policy and responsible for implementing this policy has said, no, it's going to save money because it's going to keep it's going to keep doctors from having to be on the phone for hours and hours and hours. It's going to get patients to be able to access care efficiently when they need it, not 6 months from now after they've had 3 ER stays or ER visits because of complications related to not caring for their chronic condition appropriately the first time. All of these things, CMS has said, no, that's going to save money. This is good for healthcare. CBO says, no, this is a cost control measure. It's going to cost money if we get rid of it. So that's the tension that we're in right now. Sorry,
Yeah.
I just wanted to.
No, thank you. That was a great explanation.
What's interesting is that, if you look at all of the data points and put them together, the AMA does the survey on, on prior auth with their members, and they came out, the one that came out last year was particularly alarming when you think about the cost component, that 64% of providers said that prior auth has led to ineffective initial treatment. 62% said it's led to additional office visits. 46% said it's led to immediate need for care, whether that's at the ER, urgent care, et cetera. 2 in 5 providers have had to hire staff just to do prior auth claims. And then 33, this is the part that really got me, 33% said that prior auth has led to a serious adverse event. That all costs money.
Yeah, man.
So, so it's interesting to think about what assumptions are going into that. And then I believe it was last year, maybe 2 years ago now, that Health Affairs put out a piece on how much utilization management, generally the administrative processing of it all, costs payers. And it's in the hundreds of millions of dollars. So, it's really interesting to think about how you might put all that together. Going back to the legislative front for a second, because I know, let's just keep beating this horse. I am encouraged, I want to kind of shift over there for a minute, that despite the fact that the bill doesn't cover, employer plans and, all of the prescription drugs and all the things that we would want, it does go a long way towards solving a problem. I think incremental change can be really important. It has been included in a Ways and Means package. I feel like this Congress, with so much emphasis on PBM reform, that there's a real opportunity to get some things like this that are clearly highly relevant. And it is, transparency, sort of the word of the day. I also don't want to ignore step therapy. I know we're talking a lot about prior auth, but the Safe Step Act, which would reform step therapy, provide some important guardrails, has also made a lot of progress, was included in a Senate package earlier this year. And there's a lot of bipartisan broad support for that as well. So I think—
And CSC is developing data that demonstrates that step therapy costs money as well.
Right. I mean, certainly, and I think a lot of our data, if you take some of the data points that all of our organizations have collected over the years about the impact of these things, inappropriate utilization of them on our patient population, you're sort of thinking that adds up to an awful lot of dollars and long-term costs as well, which one would think the government would care a lot about, considering they pay for a lot of Medicare. So that's kind of the state of play that gives us some optimism that there is some momentum in this Congress. I think the states have a lot to sort of show here as well, because we've made a lot of progress on both of these issues at the state level. Over 40 states have either considered or passed some sort of prior auth legislation. There were 80 bills this year alone. Step therapy, we've covered, I think we're up to 37 states now or something to that effect, which is amazing. I mean, it's not all equal. It's not all perfect. It's not all being implemented perfectly. There are some issues there, but we've been able to take some real lessons learned, which I think is really important for advancing further state efforts and our federal efforts. I think, some of the federal legislation, gold carding is another one. There's the Gold Card Act, which, would sort of allow for, if you have had 90% of your prior auth requests approved over the past 12 months, then you could get this exception. That's really important for streamlining. That's based on a bill that was passed in Texas. And now other states are being able to look at some of the lessons learned and best practices from Texas in their own efforts. So I think all of that is really, really important. Interesting little tidbit that I'll end on for the moment, which is I was looking at GovTrack about kind of the state of the Gold Card Act at the moment. It's only been introduced in the House, but it says it has a 1% chance of passing. That's their prognostication. So that's, I don't want to, I sort of like beginning and ending on a bit of a gloomy note. But, at least it provides some attention to the issue, which I think is really important.
I want to work for GovTrack this year, because I'd give everything a 1% chance of passing this year, right?
Well, and so, I mean, that does segue very well into what was going to be one of my closing questions. And so I'm gonna tease it, because I want to turn to Greg and Rachel with another level setting question first. But both Peggy and Anna, I do want to hear your thoughts on sort of the legislative outlook. Obviously, this year is, for all intents and purposes, done.
Hey, we got a month. Hey, wait.
I was going to say, some people might be surprised to hear that. So, we should talk a little bit about why that is, and what we might expect out of next year, and sort of all of these bills in the context of maybe some of the other PBM legislation and other healthcare topics that we've heard so much about this year. So I'm going to tease that, but I wanted to turn to Greg and Rachel quickly, because we just threw a whole bunch of information at folks and talked about different insurance plans and different policies affecting and why state legislation would have an impact on some of these things versus Medicare Advantage. What is Medicare Advantage as compared to traditional Medicare? Rachel, you mentioned Medicaid earlier, and what so can we just sort of reset, and Rachel, I'll go to you first, and then Greg, from the AHIP perspective, maybe you can cover private insurance plans. What are we talking about here? Why were we only talking about Medicare Advantage at the beginning when we were talking about prior auth? And how do all of those puzzle pieces fit together? You fix it.
Well, I think what you're just sort of outlining here is kind of what I was saying at the beginning, right? We have a really complicated healthcare system, which is extra complicated because we don't have a streamlined way to pay for healthcare like many other places in the world. And instead, we have this sort of complicated patchwork of public and private payer programs, right? There's Medicaid for low-income people and people with disabilities. There's the Children's Health Insurance Program for low-income kids. There's the Medicare program for people age 65 and people who are severely disabled. And then in the middle is sort of, you know, all the private insurance that one gets either from your employer or through a marketplace. And we've got different rules for every single one of those systems. And just in the private insurance space, people may go from having a marketplace individual plan to working for a small business to working for a large company or multiple companies and be changing insurance plans over the course of their lifetime. And I think it's just really hard for people to understand what that system looks like and what they need to do, given that every private insurance company has different rules about what they're going to require prior authorization or other utilization management for. What are they covering? What are they not covering? Who do you have to go to? When do you have to do it? How long is it going to take? What's the process? It's all different depending on what insurance plan you have. And the federal government has some say, lots of say in Medicare, but less say in a lot of the rest of the programs, especially in the private market, and especially when it comes to large employer plans. So it's kind of a mess. And I think one of the problems that we're trying to highlight here is that leaves patients in the position of, you know, becoming experts when they need chronic, ongoing, serious care in what those processes are and knowing what questions to ask and when to ask them, and how to manage all that as they navigate through the process.
Greg, you went from AHIP to Better Medicare Alliance. Any thoughts on how patients in sort of those sort of more private components of the healthcare system can advocate for themselves in these situations?
Yeah, absolutely. I mean, I agree. I think, you know, utilization management and prior authorization and medical coverage policies, you know, again, these can be really difficult for patients to navigate. And I really think that's why, you know, CMS and the programs that they administer, particularly Medicare Advantage, which now is 30 million beneficiaries enrolled in Medicare Advantage, really put, you know, better guardrails and consumer safeguards around the use of these tools, again, so they're used kind of appropriately and consistent with kind of clinical best practice. And that's why they're looking to establish these committees. They're looking to streamline the process as much as possible by requiring electronic prior authorization. That should, you know, reduce inefficiency in the system. You know, the inefficiency that Anna was mentioning is just as far as administrative costs. You know, plans are also taking steps to streamline the process as well. But these are, you know, Courtney, these are incremental reforms, and we have a complicated healthcare system, spoiler alert, public and private, and policy making is often, you know, siloed. It's like, you know, CMS has authority over the programs they regulate, including, you know, Medicare Advantage, Medicare, you know, Medicaid CHIP, and the ACA exchange marketplace, you know, the employer plans, which are sort of separate from that. And then there are patients that don't have any insurance at all still. And so you think about the barriers there as well. And how can we kind of design policy to really ensure that patients are well served in the coverage programs that they're enrolled in. And again, you know, credit to CMS for really tackling some of these issues. I think these are important reforms that are going to go into effect next year. It's obviously when you implement something, it's one thing to, you know, issue the final rule. A lot of it is to see, you know, how these are implemented. I think it's probably going to take some time to kind of evaluate, but really the goal is to make the process easier for patients and providers while retaining the clinical value of the tool, but really reducing these barriers that are real, that everyone here has identified, and really make progress on this important issue.
So we have identified some incremental steps forward, both on the regulatory side and the legislative front. So Peggy and Anna, I said I was going to come back to you. Peggy, what are we looking at? We said there's a 0% chance of the Gold Card Act passing this year.
Well, you did. I'm hopeful until New Year's Eve happens, but that's just how I roll.
Oh, they're gonna get out of Dodge.
But I would just start off by saying there is also hope in the idea that these insurers aren't just in Medicare Advantage and only in Medicare Advantage. The same insurers are in commercial plans. So what I learned about the insurance industry back when I was working for them was it was more efficient and logical for them to take a set of rules and apply them to all their programs. So that's the incrementalism I'm hopeful for, is that they're just going to do it because they're going to figure out it makes more sense. Also, the signals from CMS, much bigger than my bill, we're going after every federal program we can. And to Anna's point is the states are doing it. So if the states are doing, it's all happening. It's going to happen. It will happen. It is happening. And that's what's exciting. Will I get a bill signing ceremony? Who cares? Peggy Ty gets a bill signing ceremony. I mean, literally, it's not my bill, but I care because I really want that bill to pass because I think it's important to codify what it is we're talking about. So with the next couple of days really left, legislative days left, this is the first time I've heard members of Congress saying, I can plan for the holidays. I haven't planned for the holidays in a decade because there was always some continuing resolution that was dragging us out till the end of the year. So members of Congress are excited for the first time in a long time because they can plan their holidays. How weird is that, right? But that means that they want to wrap things up. They want to wrap things up because the government is funded through the beginning of next year, right? So it is, to Courtney's point, and I'm being facetious, I want it to happen tomorrow. It's probably not. But I hold out hope until the very end of the day. CMS could ruin my weekend and make my day by introducing, dropping this final rule on Friday, tomorrow. And one part of me hopes they don't, and the other part hopes they do. And then I would go to the Hill and go, hurry, let's go. Let's go. We probably have to have more time to think it through. This is only the first year of this Congress. We've got next year, and there is so much momentum. I believe it's going to happen. It's just a matter of time.
And then next year is an election year. What does your crystal ball say about that?
Well, I tend to agree with Peggy on everything that she said.
I mean, that's usually wise, but
I know.
Well, don't ask my husband that. Yeah.
I think that there is this groundswell of all of these things that we're talking about, that the proposed reg that we're hoping will get finalized any day now really is important. I mean, it says all of the right things. There are a lot of pieces of it that we haven't talked about yet. There's a huge continuity of care piece in there around payer to payer, sharing of previous prior auth claims. We've always said that, healthcare to follow the patient and not patients constantly having to follow healthcare. And that actually sort of puts a down payment on that, which is amazing. So there's a lot in there. So that'll be interesting to see how that comes down. I do think that we have the best chance we've ever had for both the prior auth bill and the step therapy bill, given the emphasis this Congress on PBM reform and how, just like I said earlier, highly relevant these are. So obviously the timing and the politics of an election year matter greatly to this, but I sort of got out of the business of trying to make predictions with Congress because I'm always wrong. So I suppose if I was going to make a prediction, then I would say, no, it's absolutely not going to pass. No chance.
It's like bringing an umbrella. I don't
Or go work at GovTrack.
When you want it to stay sunny.
In the meantime, we're going to continue, at the state level for sure, leveraging both states that still are in need of protections and laws and going back into states that have passed them to just make sure they're being implemented. Of course, that's really important, but also, leveraging the stakeholders there to put pressure on Congress as well. So hopefully we can have even more of a sort of comprehensive approach in the coming months.
Well, just if I could add to Greg's point, there's a lot of work to be done even after passage, finalization of the rules and passage of the law, because that whole process of implementation is going to take time, and it should be done thoughtfully, correctly, and be analyzed as it's being done. And I think all of us should be active players in making it work.
Well, and that ties in nicely to our first panel as well, as we were talking about IRA implementation and sort of what the stakes are if folks get that wrong. And that I think is a really great point to end on, that advocacy it's a full-time job. But that is also why we are here. That's why all of my colleagues and my colleagues from the first panel, we do what we do. And I'll just emphasize that point again. It's our job to open the doors and make sure that the patient voices are in the room. I encourage everybody who is listening to these sessions to find ways to engage with their advocacy organizations, their professional associations, and get out there and get involved. And I know that means that you're fighting for yourself every day with your doctors and your insurance companies, and you're lending your time and your voice to these broader efforts, but it really does make a difference, and we can make incremental progress. So thank you so much to our panelists. We are at time. I didn't see any questions in the Q&A, but I'll ask you to hold on for a second, panelists, while I close things up, if anybody has any last minute questions.
I have one tip that I've been sharing with patient advocates is many of us are very calendar driven. Why not put on your calendar once a month, once every other month, do advocacy, right? Put in a little calendar notice that says, I'm going to go do this. I'm going to write that letter. I'm going to send a message to my policy, to policymakers. I'm going to, like something on social media. Make yourself do it by setting your own calendar notice. And I've found my patient advocate friends have been saying, that's so helpful. I'm glad you made me do that.
And we're here to make that process easier for you. If you need talking points, if you need a draft letter, please reach out. That's what we're here for. It's a really great point, Peggy. Thank you. All right. So today we've heard from a number of impressive panelists, and we have a lot to think about going into 2024. We continue to work together, engaging on these pressing issues to keep patient voices and perspectives at the forefront of our work. We will ensure that utilization management is used appropriately. We know, as mentioned many times today, there's still a lot of work to be done, but we're stronger together. There are many calls to action today, including writing your legislators about these issues and sharing your personal stories. Engage with your coalitions, other patients in your community, and your members of Congress, both in district and come to DC. And of course, those pesky regulatory agencies. So thank you again to our speakers and panelists for sharing your expertise with us today. We're so grateful to you for taking the time to discuss this important topic. As a reminder, today's summit was recorded. If you missed any of today's presentation, we will be sharing it with participants via email very soon. And thank you again to our sponsors, Bristol Myers Squibb, GSK, Janssen, Novartis, and Sanofi. And thank you to all of our attendees for joining us. Please reach out to Maxine Miller at mmiller@cancersupportcommunity.org if you have any questions. And please be sure to fill out the short survey when you leave. The feedback really does mean a lot to us and helps to inform our future sessions. Thank you all again. And those of you who are participating in our Steps Therapy Research Board meeting, you'll log out. You should have received a separate link. But please reach out to Dawn if you have any issues, or Maxine, whose email I just mentioned, mmiller@cancersupportcommunity.org. Thank you again. It was great to see everyone. Happy holidays.
Thank you.
Thank you.